Hi, welcome to Module 3, Medical Nutrition Therapy. I hope you enjoy this section of the course. Please let me know via email or discussion board if you have questions about content. If you are having problems viewing or hearing the presentation, please contact the program administrator. People with diabetes should receive diabetes self-management education according to national standards and diabetes self-management support when their diabetes is first diagnosed and as needed thereafter. Because diabetes nutrition therapy can result in cost savings and improved outcomes, such as a reduction in A1C, nutrition therapy should be adequately reimbursed by insurance and other payers. A registered dietitian is an important part of the diabetes healthcare delivery team. The role of the dietitian in the prescription and implementation of medically prescribed nutritional recommendations can be the crucial link to successful lifestyle changes. The priority of nutrition therapy for type 2 diabetes is to implement lifestyle strategies that will reduce hyperglycemia and hypertension, as well as improve dyslipidemias. Initiation of a medical nutrition therapy program begins with a thorough patient assessment, which should allow the provider to focus on a patient's metabolic needs, gauge lifestyle patterns, help set goals, guide professional intervention and evaluation. The information obtained in the assessment process drives the development of specific nutritional recommendations. The nutrition goals for people with diabetes. Number 1 is to attain and maintain normal or as close to normal range with their glucose as is safely possible. Also, good control of blood pressure and lipid levels is recommended. Another goal is to prevent, delay, or treat conditions with nutrition-related implications, such as hypoglycemia, sick days, kidney disease, and heart disease. While doing this, it is important to try to maintain the pleasure of eating. You want to use scientific evidence to teach what food choices to limit. The ADA recommendations for blood preprandial glucose is 80 to 130 milligrams per deciliter. Target goals recently changed from 70 to 130 to the current recommendation to better reflect new data comparing actual average glucose levels with A1C targets. The 1 to 2 hour postprandial goal is less than 180. These goals are for non-pregnant adults. The ADA recommended lipid goals for cholesterol is less than 200. With an HDL of greater than 40 for men and greater than 50 for women. LDL of less than 100 and triglycerides of less than 150. Cholesterol and triglycerides travel in the bloodstream as part of lipoprotein particles. Lipoproteins are classified by density and size. Low-density lipoproteins, or bad cholesterol, usually carry cholesterol. High levels of LDL are dangerous because they deposit the cholesterol in the vascular epithelium. However, high-density lipoproteins, or HDL, the so-called good cholesterol, carry cholesterol away from blood vessels back to the liver where it is disposed of. Triglycerides are made of saturated and unsaturated fatty acids. The goal is to intensify lifestyle therapy and optimize glucose control for patients with elevated or uncontrolled lipid levels. The ADA recommended blood pressure goal is less than 140 over 90. Some patients may benefit from a blood pressure goal of less than 130 over 80, if this can be achieved with undue treatment burden. Studies indicate that the previous blood pressure target of 140 over 80 didn't improve outcomes enough to balance the risk of side effects, such as orthostatic hypotension and polypharmacy. Now that we know what the goals should be for medical nutrition therapy, let's discuss estimating a patient's energy requirements. The preferred method for determining calorie requirements is to calculate it based on the patient's usual eating style. By conducting a thorough 24-hour recall and food history assessment, a close approximation of the typical intake of calories and grams of carbohydrate, protein, and fat can be determined. This level can be adjusted based on the mutually determined goals of blood glucose control, weight change, and lifestyle. Alternatively, formulas can be used to approximate the number of calories needed to maintain weight. Once maintenance calories are set, the calories can be adjusted up or down to gain or to lose weight. For weight maintenance, an easy way to calculate the calories needed would be to multiply 25 calories per kilogram of desirable body weight per day, which is also approximately 11 calories per pound. If the patient is moderately active, add 20% to that. If they are very active, add 40%. The key is to add calories if weight gain is desired according to the patient's goals. A calorie intake below basal requirement will lead to the use of non-carbohydrate fuels, ideally fat, leading to weight loss. To gain weight, we must do the opposite. When estimating energy requirements for weight loss, a decrease of approximately 3,500 calories equals 1 pound or 2.2 kilograms of weight loss. A decrease of 500 calories per day means a patient should lose approximately 2 to 4 pounds per month. Losses of slightly more than this might be appropriate for the most highly motivated individuals, but may not be for an overweight or obese person with type 2 diabetes unless this weight reduction is medically supervised. Other factors that may affect daily caloric needs: gender, size, age, stress, and adaptation. Women usually require fewer calories than men because they are smaller in size and frame and have less muscle mass. Smaller people usually require fewer calories to maintain their weight. Younger, more active people need more calories than older people, especially during periods of growth. Caloric needs increase with some types of physical stress, such as after severe injury or illness or during pregnancy and lactation. Calorie needs decrease as a person loses weight. It requires fewer calories to maintain less body weight. The ADA does not recommend a certain percentage of macronutrients. Distribution should be based on individualized assessment, preferences, and metabolic goals. Evidence suggests that there is not an ideal percentage of calories from carbohydrate, protein, and fat for all people with diabetes. Now let's talk about macronutrients. There are 3 types of nutrients: carbohydrate, protein, and fat. All provide calories. Alcohol, while not a macronutrient, does provide calories as well. Carbohydrate, an immediate fuel source, provides 4 calories per gram. Protein provides a slower, more sustained energy supply, also contributing 4 calories per gram. Protein, however, is better used for functions other than providing energy, such as building and repairing body tissue. Fat, a concentrated energy source, serves as a long-term storage depot for energy. It provides 9 calories per gram. Alcohol provides 7 calories per gram. Carbohydrate is the primary source of fuel for the body. The body can use this fuel for immediate needs, or it can store it in the liver and muscle in the form of glycogen for future use. Stored energy provides for varying energy requirements throughout the day and on an ongoing basis. Evidence is inconclusive for an ideal amount of carbohydrate intake for people with diabetes. Therefore, collaborative goals should be developed with the individual with diabetes. The amount of carbohydrates and available insulin may be the most important factor influencing the glycemic response after eating and should be considered when developing the eating plan. Monitoring carbohydrate intake, whether by carbohydrate counting or experience-based estimation, remains a key strategy in achieving glycemic control. For good health, carbohydrate intake from vegetables, fruits, whole grains, legumes, and dairy products should be advised over intake from other carbohydrate sources, especially those that contain added fats, sugar, or sodium. Carbohydrate has 3 key destinations. It is used to provide for immediate energy needs. It is stored as glycogen, primarily in liver and muscle, to serve as a rapidly accessible energy supply, such as what would be used during sudden activity. It is converted to fat, an almost unlimited potential storage space that can't be used when glycogen stores are filled. Insulin must be present for glucose to take any of the 3 pathways, including the storage of fat in adipose cells. Proper insulin use, balanced in a physiologic manner with carbohydrate intake, should not lead to excessive weight gain, although in the short run, some increase in weight may occur. Research shows that eating 15 grams of carbohydrate from sugar, such as maple syrup, has approximately the same effect on the blood glucose as eating an equivalent amount of carbohydrate from a starch, such as bread. In fact, studies show that when individuals choose a variety of foods containing either starches or sugars in meals, if the total amount of carbohydrate is the same, the glucose response will be essentially the same. A key education point for patients is that because foods containing either starches or sugars are digested into glucose at approximately the same rate, it is important to control the total amount and not the type of carbohydrate consumed. Still encourage intake of concentrated sweets in moderation, as these foods are often high in calories and fat with little or no nutritional value. The glycemic index is a measure of how quickly blood glucose levels rise after eating a particular type of food. The effects that different foods have on blood glucose levels vary considerably. The glycemic index estimates how much each gram of available carbohydrate in a food raises a person's blood glucose level following consumption of the food, relative to the consumption of pure glucose. Glucose has a glycemic index of 100. A practical limitation of the glycemic index is that it does not take into account the amount of carbohydrate actually consumed. A related measure, the glycemic load, factors this in by multiplying the glycemic index of the food in question by the carbohydrate content of the actual serving. Foods with a lower glycemic index have less of an effect on blood glucose than do foods with a higher glycemic index. Because of the difficulty of relating glycemic index with portion sizes, the glycemic load is an easier way to measure the effect of a food. A glycemic load of 10 or less is low, 11 to 19 is medium, and 20 or more is high. The ADA does not support use of the glycemic index or glycemic load as a primary method of meal planning. However, not all carbohydrates have the same effect on blood glucose levels. Thus, while it is not necessary to eliminate potatoes, it is important for people with diabetes to choose a variety of carbohydrate foods each day and to understand the differences among the various choices. Fructose, consumed as free fructose, may result in better glycemic control compared with isocaloric intake of sucrose or starch, and free fructose is not likely to have detrimental effects on triglycerides as long as intake is not excessive. Free fructose is naturally occurring fructose, such as what is found in fruits. People with diabetes should limit or avoid intake of high fructose corn syrup, which is often used to sweeten sugar-sweetened beverages. Doing this may reduce risk for weight gain and worsening of cardiometabolic risk profiles. Minimizing intake of sucrose or table sugar and sucrose-containing foods to avoid displacing nutrient-dense food choices is recommended. When eating sucrose, substitute for other carbohydrate sources. Cover with insulin or other glucose-lowering medication. Eat within the context of a healthy diet and avoid excess energy intake. Now let's talk about artificial sweeteners. There's no evidence to support that the use of hypocaloric sweeteners and sugar alcohols cause weight gain, weight loss, or improve glycemic control. Use of hypocaloric sweeteners has the potential to reduce overall calorie and carbohydrate intake if substituted for caloric sweeteners without compensation by intake of additional calories from other food sources. The FDA has reviewed several types of artificial sweeteners and sugar alcohols for safety and approved them for consumption by the general public, including people with diabetes. Examples of hypocaloric sweeteners include saccharin, which is in the pink packet, that's sweet and low, aspartame, which is a blue packet, that's also known as Equal, and sucralose in a yellow packet, which is also known as Splenda. Truvia or erythritol is more of a sugar alcohol. It's in a green packet. Other sugar alcohols include glycerol, hydrogenated starch hydrolysates, isomalt, mannitol, sorbitol, and xylitol. Some people prefer to use the regular version of a food and cut back on serving size instead of buying the sugar-free version, and that is always an option you can give your patients. Disadvantages to using artificial sweeteners include the fact that food products containing these may still have a significant amount of carbohydrate, calories, and fat. There is often more saturated or trans fat in your sugar-free products. Sugar alcohols can also have a laxative effect or other gastric symptoms, so it's important to remind your patients that they should watch their portion size so they do not have too much sugar alcohol at one time. And then sugar-free foods cost more in general. It has recently been discovered that fiber can be a very, very important part of the diet in someone who has diabetes. Fiber refers to a group of carbohydrate foods that are of plant origin. The human digestive system cannot digest or absorb fiber. There are two types of fiber. Foods high in insoluble fiber are wheat bran, bran flakes, bran muffins, and whole wheat bread. Insoluble fiber absorbs but does not dissolve in water, increasing gastrointestinal transit time. This fiber is not digested and contributes to stool bulk, occasionally acting as a laxative. They also have the advantage of being useful in treating dyslipidemias as compared to insoluble fibers. Foods high in soluble fiber, however, include apples, citrus fruits, oat bran, oatmeal, dried beans, and peas, and many vegetables. Soluble fiber slows gastric emptying, which can affect glycemic response if large enough quantities are eaten, and thus can be useful for people with diabetes. When dissolved in water, soluble fiber forms a gummy gel, which slows down glucose absorption and blunts postprandial glucose elevations. The current recommendation for fiber intake is to aim for a minimum of 25 to 38 grams of fiber per day. It is important to remind your patients that they should drink at least 8 cups of sugar-free beverages each day, as a high-fiber diet without enough fluid can lead to constipation. The average fiber intake in the United States is approximately 8 grams per 1,000 calories. People with diabetes should consume at least the amount of fiber and whole grains recommended for the general public, which is 14 grams of fiber per 1,000 calories consumed per day. Protein, which is also a macronutrient, should be individualized to meet the goals of the patient. Protein provides energy to the body in the setting of carbohydrate insufficiency. The recommended daily allowance for protein is 0.8 grams per kilogram of body weight, which constitutes approximately 10 to 35% of total calories for the day. With regard to type 2 diabetes, protein may aid in creating a sensation of fullness, maintaining muscle mass during weight reduction, and improving glucose uptake by muscles without increasing postprandial blood glucose. More healthy sources of protein include skinless poultry, fish and seafood, lean meat, legumes, and tofu. For people with diabetes and no evidence of diabetic kidney disease, evidence is inconclusive to recommend an ideal amount of protein intake for optimizing glycemic control or improving one or more cardiovascular disease risk measures. Therefore, goals should be individualized. In individuals with type 2 diabetes, ingested protein appears to increase insulin response without increasing plasma glucose concentrations. Therefore, carbohydrate sources high in protein should not be used to treat or prevent hypoglycemia. The ADA does not recommend protein reduction for patients with diabetic kidney disease. Fat has a less immediate effect on blood glucose levels than carbohydrate and protein. Yet, fat delays the emptying of food into the intestines and thus may slow down the rise in blood glucose if included as part of a mixed meal. A high-fat meal may result in a high blood glucose many hours later than expected due to delayed gastric emptying of carbohydrate and protein. Evidence is inconclusive for an ideal amount of total fat intake for people with diabetes. Therefore, goals should be individualized. Fat quality appears to be far more important than quantity. Most saturated fats can increase cholesterol levels and are more harmful than unsaturated fats. Animal fats, which are usually solid at room temperature, are saturated fats. Palm and coconut oil are also saturated. Saturated fats raise blood cholesterol levels by interfering with the entry of cholesterol into cells. This causes cholesterol to remain in the bloodstream longer and to become part of the plaque that builds up in the blood vessel walls. Cholesterol intake should be limited to less than 300 milligrams per day for people with diabetes. Trans fat is a type of fat formed from partial hydrogenation of oils, a chemical process that changes a liquid oil into a solid fat. The process involves adding hydrogen to liquid oil and turning it into solid or semi-solid fat. Trans fats are found in many processed foods, including snack foods, cookies, some margarines, and fast foods. Trans fats raise LDL cholesterol level and significantly increase the risk of coronary artery disease more than any type of fat. For this reason, it should be limited as much as possible. The amount of dietary saturated fat, cholesterol, and trans fat recommended for people with diabetes is the same as that recommended for the general population, with less than 10% of calories from saturated fatty acids to reduce cardiovascular disease risk, with foods high and replacing saturated fat with foods high in monounsaturated fatty acids and polyunsaturated fatty acids. Monounsaturated fats, such as olive, peanut, and canola oils, and polyunsaturated fats, such as corn, soy, safflower, and sunflower oils, may help reduce cholesterol levels and are therefore preferred over saturated and trans fats. Unsaturated fats are liquid at room temperature, whereas saturated and trans fats are solid. However, unsaturated fats contain just as many calories as all other fats. A key point with your patient to make is even if they switch to a healthier fat, they still have to watch their calories or the healthy fats will cause weight gain. Evidence does not support recommending omega-3 supplements for people with diabetes for the prevention and treatment of cardiovascular events by reducing triglyceride and blood pressure levels and decreasing the risk of arrhythmias. As recommended for the general public, an increase in foods containing long-chain omega-3 fatty acids and omega-3 linolenic acid is recommended for individuals with diabetes because of their beneficial effects on lipoproteins, prevention of heart disease, and associations with positive health outcomes in observational studies. The recommendation for the general public to eat fish at least 2 times per week is also appropriate for people with diabetes. Micronutrients and herbal supplements. There is no clear evidence that there is benefit, a glucose lowering benefit in people who have diabetes. Routine supplementation with antioxidants such as vitamins E, C, and carotene is not advised because of lack of evidence of efficacy and concern related to long-term safety. There is insufficient evidence to support the routine use of micronutrients such as chromium, magnesium, and vitamin D to improve glycemic control in people with diabetes. However, research recommends treatment for those individuals with lower than normal vitamin D levels. There is insufficient evidence to support the use of cinnamon or other herbs and supplements for the treatment of diabetes. It is recommended that individualized meal planning include optimization of food choices to meet recommended dietary allowance and dietary reference intakes for all micronutrients. If adults with diabetes choose to drink alcohol, they should be advised to do so in moderation. Moderation is 1 drink per day or less for adult women and 2 drinks per day or less for adult men. Alcohol consumption may place people with diabetes at increased risk for delayed hypoglycemia, especially if taking insulin or insulin secretagogues. Education and awareness regarding the recognition and management of delayed hypoglycemia is warranted. 1 alcohol-containing beverage is defined as a 12-ounce beer, a 5-ounce glass of wine, or 1.5 ounces of distilled spirits, each containing about 15 grams of alcohol. Abstention is advised for those with a history of alcohol abuse or dependence, women during pregnancy, medical conditions such as liver disease, pancreatitis, advanced neuropathy, or severe hypertriglyceridemia. Advise patients to consume alcohol with food for hypoglycemia prevention. If one chooses to drink alcohol and has not been cautioned against it, limit intake to 1 drink per day for women and 2 drinks per day for men. For sodium, the recommendation for the general population is to reduce sodium to less than 2,300 milligrams per day, and this is also appropriate for people with diabetes. This amounts to a teaspoon of salt per day. For individuals with both diabetes and hypertension, further reduction in sodium intake should be individualized. Considerations must be given to issues such as palatability, availability, and additional cost of specialty low-sodium products, and the difficulty in achieving both low-sodium recommendations and a nutritionally adequate diet given these limitations. Because many people with type 2 diabetes have either high blood pressure or are salt sensitive, it's recommended that these people be educated on ways to reduce sodium intake in the diet. When I educate patients about sodium intake, I usually start with foods that are most high in sodium, such as processed meats, canned soups and vegetables, and lunch meats. Let's switch over to obesity. Since about 90% of the population of people with diabetes has type 2 diabetes, there is a high majority of our patients who are overweight or obese. Obesity is measured using a body mass index. The BMI evaluates weight in relationship to height and is the traditional gauge to measure obesity. It is defined as a body weight in kilograms divided by the square of height in meters, or the weight in pounds multiplied by 703 and divided by the square of height in inches. According to the National Heart, Blood, and Lung Institute, overweight is defined as a BMI of 25 to 29.9. Obesity is defined as a BMI greater than 30, and severe obesity as a BMI of greater than 40. Another key measure in weight and body fat assessment is waist circumference. It is now known that waist circumference is a stronger predictor of cardiovascular disease outcomes than BMI. Measuring the waist circumference gives an indication of the extent of abdominal fat or central adiposity, which is fat that is more metabolically active. A high amount of abdominal fat predisposes a person not only for heart disease, but also for type 2 diabetes, high blood pressure, and dyslipidemia as well. American men with a waist circumference of 40 inches or greater and American women with a waist circumference of 35 inches or greater are at increased risk for cardiovascular disease. In other ethnic groups, such as Asians, the risk starts to increase at a much lower waist circumference. It is important to recommend to all patients with diabetes who are overweight or obese a weight loss program. With weight loss, insulin works more effectively and less insulin is needed. Triglyceride levels also decrease and glucose tolerance improves, signifying improved diabetes control. A 10 to 20 pound weight loss is sufficient to significantly improve insulin sensitivity and glycemic control. This would amount to a 7 to 8.5% of body weight. A person who is 50 pounds overweight might be given a goal of losing 10 pounds over a 3 to 6 month period. This goal is realistic and not so overwhelming. In addition, someone 50 pounds above ideal body weight may only need to lose 10 to 20 pounds to have a significant impact on metabolic parameters. There is no optimal macronutrient distribution for weight reduction. Weight loss is achieved by reducing energy intake and maintaining a healthful eating pattern. A weight loss goal of 1/2 to 2 pounds per week is recommended for most. To lose weight, people must either take in fewer calories or burn up more calories or both. Exercise alone does not usually result in significant weight loss. It is effective when accompanied by a lower caloric intake and behavioral modification. Other forces that would affect weight reduction are age, ethnic customs and belief, family habits, lifestyle factors, and psychological issues. Unfortunately, in many cultures, obesity is confused with prosperity and good health. Obesity can also run in families, both through inherited tendency and also by learned eating habits and ethnic diet preference. Psychosocial issues can also contribute. Loneliness, depression, and anxiety can lead people to seek gratification by eating. With weight reduction, lifestyle change should be the primary approach. It is important when counseling that you counsel on nutrition therapy, physical activity, and behavioral change. It is also important that a patient receives ongoing support. The most recent recommendations recommend considering bariatric surgery for adults who have BMI greater than 35. Now let's talk about planning meals. The nutrition prescription, which optimally is designed by a registered dietitian, involves calculating caloric levels and determining appropriate combinations of nutrients while taking into account the weight, clinical goals, activity level, and health status of the patient. Goals for healthy eating should include individualized calorie levels for growth or maintenance, weight loss, blood glucose control, normalization of blood lipid levels, and blood pressure control. The first step in implementing a nutrition prescription is to perform a careful patient assessment. This assessment should cover the patient's current habits, issues, and needs with respect to the nutritional recommendations. To maintain glucose homeostasis, each of the 3 components of nutritional therapy must be considered. The proper type of food must get into the body in the proper amount and at the proper time. Doing so allows the available insulin, whether endogenous or exogenous, to be matched with the food type and quantity in order to ensure proper utilization of the incoming nutrients for immediate energy needs or storage for later use. Patients who are new to diabetes can make immediate improvements in their eating habits until they have the opportunity to meet with a registered dietitian. They can be given guidance in choosing healthy foods using a picture of a plate divided into suggested servings. It is not expected that calories would be calculated at this point in the process. This is just a starting point. So what is recommended when someone is newly diagnosed is to first give them healthy eating guidelines. Then you can move to pre-planned menus, use of exchange or food choice lists, or use of carb counting methods. When teaching to follow healthy eating guidelines, emphasize limiting saturated and trans fats and added sugars, selecting substitute foods, food grouping, and portion size and timing of meals. Also emphasize eating consistent amount of carbohydrate day to day, and also increasing intake of fresh fruits and vegetables and whole grain carbohydrates. The plate method gives the patient a visual demonstration of a balanced diet and teaches them an easy method of determining portion sizes. Half of the plate is for the non-starchy vegetable serving. The other half of the plate is divided into quarters. 1/4 of the plate is for a 3-ounce protein food, and the other quarter for starches. For a balanced meal, add a fruit and a dairy food. The plate method is an easy method to use because it helps with portion control, especially for meat and starches. It works best with a 9-inch plate and does not require precise measuring of foods. Following pre-planned written menus can be helpful for patients who would benefit from having specific written instructions with less flexibility. While this approach lacks variety, it emphasizes structure for those who need it. A food choice list, also known as an exchange list, programs are useful for patients who are willing to follow a more structured system to control blood glucose or weight, but want some flexibility to create their own menus. Food choice lists categorize foods based on composition and by grouping foods that have a similar calorie, carbohydrate, protein, and fat content. Within each group, food may be substituted or exchanged for one another in the designated amounts. Carbohydrate counting, however, is based on the premise that carbohydrate foods have the greatest impact on blood glucose. Since almost all of it is converted to glucose and all forms of carbohydrate have about the same effect on the blood glucose. Therefore, carbohydrate foods can be easily exchanged for one another. Though the timing of food consumption is important, newer pharmacologic treatment agents have made the need for precision of meal timing less crucial. For people whose diabetes is not insulin treated, the total daily caloric intake should be modified based upon the person's individual goals. For these people who tend to skip meals, distribution of calories through the day may need to be addressed. For people treated with insulin, food intake should coincide with the peak action times of the insulin. All patients with diabetes should try to eat 3 well-balanced meals per day. Now let's discuss some different types of eating patterns, in particular the Mediterranean, DASH, and vegetarian patterns. The Mediterranean style food pattern is based on eating plant foods, lots of fruits, vegetables, whole grains, beans, nuts, and seeds. It's a minimally processed diet that has seasonally fresh foods and locally grown foods. Fresh fruit is the typical daily dessert, and concentrated sugars or honey is consumed only for special occasions. Olive oil is the principal source of dietary lipid. Dairy products are consumed in low to moderate amounts, with fewer than 4 eggs per week. Red meat is consumed in low frequency and amounts, and wine consumption in low to moderate amounts, generally with meals. The DASH diet is a type of eating pattern used to help people reduce hypertension levels. It includes a sodium intake of less than 1,500 milligrams per day. It also promotes loss of excess body weight and increasing consumption of fruits and vegetables with low-fat dairy products. The 2 most common ways of defining vegetarian diets in the research are vegan diets, which are diets that avoid all flesh foods and animal-derived products, and then there's vegetarian diets, diets devoid of all flesh foods but including egg and or dairy products. Features of a vegetarian eating pattern that may reduce risk of chronic disease include lower intakes of saturated fat and cholesterol, and higher intakes of fruits, vegetables, whole grains, nuts, soy products, fiber, and phytochemicals. It is vitally important in this type of an eating pattern that a patient gets plenty of protein in their diet, which is the challenge with the vegetarian eating plan. These plans can also be high in carbohydrate, so carbohydrate counting might also be very important in this diet plan. For a person with type 2 diabetes, whose diabetes is being controlled by meal planning and physical activity alone, specific metabolic goals have been defined by the ADA. The ADA recommends an achieved A1C level that is below 7% in most patients. If this goal is not met within a defined time period, 6 to 8 weeks, then more aggressive treatment is warranted. Monitoring progress toward reaching goals and helping evaluate the overall effectiveness of the meal plan can be done using a number of parameters. It is important to ask these questions. For glucose control, you want to ask the question, are the glucose monitoring levels approaching target levels? Is there improvement in the fasting pre-meal and postprandial levels? Is the patient having frequent episodes of hypoglycemia or hyperglycemia? Other questions to ask yourself, is the A1C level below 7? Are lipid levels improving? Is the patient losing or gaining weight? Is the patient satisfied with the approach that has been chosen? Is the patient feeling hungry all the time? Are they meeting their overall nutritional needs? It's important to ask these questions in order to develop a plan that best fits the patient. In 1994, the U.S. government mandated that specific nutritional information be provided on food labels, making it easier for everyone to determine more precisely what they are consuming. It is mandatory on food labels to list ingredients, calories per serving, protein, carbohydrate, fat, and trans fat. When reading food labels, patients should be advised to pay particular attention to the serving size, as the other nutritional measures, such as calories, fat, and carbohydrate, are based on these parameters. In general, an example of a healthy food product is defined as the following and can be used in comparing items. A healthy food product should have saturated fat level of less than 1 gram per serving. It's considered low fat if it has less than 3 grams per serving of fat, fiber greater than 3 grams per serving, and for sodium in an entree less than 800 milligrams per serving, or for a snack less than 400 milligrams per serving. A common error is to assume that all dietetic and sugar-free foods are low in calories or have no carbohydrate. This is not true and can be misleading to many patients. Advise your patients to look for total grams of carbohydrate on the food label. This will provide the patient with true information as to the level of which the product will affect the blood glucose. People with diabetes are often asked to keep food records of their food and carbohydrate intake, as well as activity level and blood glucose results. A completed food record is an invaluable tool to determine if the current diabetes treatment plan is successful or not. Encourage patients to keep at least a 3-day food record prior to seeing a dietitian for the first time. Thereafter, a dietitian may ask the patient to continue to keep the food records, especially if the patient is experiencing fluctuating blood glucose levels, is trying to lose weight, or is in the process of evaluating an insulin to carbohydrate ratio. When counseling a patient to keep a record, recommend keeping a food record that lists times eaten, foods, and portions. This will allow the individual to learn how different amounts of carb affect their blood glucose levels. There is always something learned from mistakes. If the blood glucose is above the target range, the amount of carb eaten in the last meal should be reviewed. The same meal should be consumed again, but with smaller portions of carbohydrate, to see if this helps reach the desired blood glucose target. Now let's learn more about carbohydrate counting. The ADA no longer recommends that a specific percentage of calories come from carbohydrate. However, it does recognize in its nutrition recommendations that while the RDA for carbohydrate is 130 grams per day, is an average minimum requirement. Carbohydrate counting remains a primary component of meal planning for people with diabetes. Though the ADA gives no defined recommendation for percentages of carbohydrate, the Joslin Diabetes Center's clinical nutrition guideline for overweight and obese adults with type 2 diabetes, prediabetes, or at high risk for developing type 2 diabetes recommends approximately 40% of calories from carbohydrate. The total not to be less than 130 grams per day in accordance with the recommended dietary allowance. The benefits of carb counting include it helps stabilize blood glucose levels, it can be combined with healthful eating patterns, it gives more flexibility to enjoy all foods, and it's easy to access the nutritional content because carbohydrate is listed on a food label. We know that 100% of consumed carbohydrates are converted to glucose and serve as the main source of energy in our diet. Carbohydrate sources are starches, fruits, milk and yogurt, other carbohydrates, which would include concentrated sweets, and non-starchy vegetables such as peas, potatoes, and corn. One serving of carbohydrate is the same thing as 15 grams of carbohydrate. Carbohydrate on a food label is listed in grams. Usually, 1/2 cup of a carbohydrate containing food is 1 serving or 15 grams of carbohydrate. The exception would be dairy products. Some of the examples of 15 grams of carbohydrate include 1/2 cup of peas, corn, or potatoes, 1 slice of bread, 1/2 cup juice, 1 cup milk, or 1/2 cup ice cream. The food label is generally the most reliable place to obtain the carbohydrate information. For milk and yogurt, usually a 1 cup is a portion size for what would be considered 15 grams of carbohydrate. It is recommended that when buying dairy products, you buy low-fat, light dairy products. For instance, there is a lot more calories in regular yogurt than in light yogurt. Light yogurt is usually sweetened with an artificial sweetener and therefore would contain less carbohydrate and have less of an effect on the blood glucose. For sweets, desserts, and other carbohydrates, calories vary based on the fat content. These products do not include important vitamins and minerals. And also, it is important to teach your patients and to remember that sugar-free does not mean carbohydrate-free, and fat-free may contain extra carbohydrates added to compensate for flavor. Non-starchy vegetables. When I'm teaching patients, I usually call them garden vegetables or rabbit food. And 1/2 cup cooked or 1 cup raw contains approximately 5 grams of carbohydrate. Examples of non-starchy vegetables include green beans, broccoli, carrots, celery, peppers, lettuce, summer squash, and tomatoes. Combination foods generally provide the patient with the most frustration when learning how to carbohydrate count. Fat and protein do not contain carbohydrates, but they may slow down the absorption of carbohydrate in a meal or snack. A high-fat, high-protein, and high-carb meal, like pizza, may not affect the blood glucose reading 2 hours after eating, but a delayed increase 4 to 6 hours may be seen after eating foods like pizza, a burger with fries, or Chinese food. Protein and fat do not contain carbohydrate, but they do have calories. Therefore, eating too much can cause weight gain. To count carb choices, because carbohydrates can be counted either using the choices or by counting grams of carbohydrate. To count carb choices, count servings of starch, fruit, and milk. Consider each carb choice to have 15 grams of carbohydrate. To count grams of carbohydrate, look at nutrition labels or food lists, such as the Exchange List or a book called The Calorie King. Use food models and food labels from food sources to show serving sizes and where to find grams of carb on the nutrition label. Carb counting versus carb guessing. In the beginning, it will be difficult to estimate the amount of carb in a serving. It will take time and practice. Carb guessing leads to either under or overestimating the actual amount of carbohydrate in a serving. This may result in a high or a low blood glucose level. Use measuring cups or weights or weigh the food. This will show how to compare usual serving sizes to the actual serving size on the nutrition label. Weighing and measuring foods 1 time per week will help you learn how to accurately eyeball serving sizes. The Calorie King book contains a large food list with the breakdown of calories, fats, and carbs from each item. The Calorie King also has a more extensive database online. The Food Exchange List for Diabetes is a booklet from the American Diabetes Association and the American Dietetic Association that details serving sizes, added fiber, extra fat, and sodium. When measuring food portions, most forget an actual serving or portion size. Measuring food portions helps to control the food portion and provides a frame of reference when dining out. Helpings when dining out may be 1, 2, or 3 times what they should be. Household items can be used to determine serving size equivalents. For instance, 1 thumb equals 2 tablespoons of avocado. 1 deck of cards equals 3 ounces of meat. 1 fist equals 1 baked potato. 1 teaspoon margarine equals 45 calories. 1 golf ball equals 1/4 cup of cottage cheese. 1 large marshmallow equals 2 tablespoons peanut butter. 1 dice equals 1 ounce of cheese. Snacks may be a part of a meal plan and usually should contain only about 15 to 30 grams of carbohydrate. Snacks may be needed at bedtime to prevent blood glucose going too low during the night. Bedtime snacks should be something starchy because it takes longer to metabolize. Examples would be bread, crackers, or cereal. This slide lists some different snack idea options, such as 3/4 ounce of pretzels or chips, which is equivalent to a small handful. A 1/2 cup of regular ice cream or 2 fun-sized candy bars. 1/2 cup regular pudding, 5 vanilla wafers, 2 small cream-filled cookies, 3 cups of popcorn. Fiber and sugar alcohols. Since fiber cannot be digested, if there is 5 grams or more of fiber per serving, subtract half the fiber grams from the total carbohydrate grams when determining an insulin dose. For sugar alcohols, it is a sweetener but still has some carbohydrate content. In a food product with a sugar alcohol, you also can subtract half of the sugar alcohol grams from the total carbohydrate grams. For example, on this food label, the serving size is 1 cup. 1 cup contains 10 grams of dietary fiber and 6 grams of sugar alcohol. Since there is more than 5 grams of fiber per serving, you would subtract 5 from the total grams of carbohydrate, which is 30. You could also subtract 3 of the sugar alcohol grams from the 30 grams of total carbohydrate. This is an example of how to calculate insulin using carb choices. The patient is prescribed 1 unit of insulin for every carb choice. The patient is going to eat 3/4 cup of cereal, a 1/2 of a banana, and 1 cup of milk. The carb choices in this meal are equal to 3. So if the patient should get 1 unit of insulin for every carb choice, 1 times 3 equals 3 units of insulin. To calculate insulin dosing by counting grams of carbohydrate, if the physician prescribes 1 unit of insulin for every 15 grams of carb, and the patient eats 1 burger patty, 1 hamburger bun, 1/2 cup peas, plus 1 small apple, the total grams of carbohydrate in this meal is 60. Divide 60 grams of carb by 15, and the patient would receive 4 units of insulin. How to know if you are carb counting correctly? The best way to be able to determine this is to check the blood glucose before meals and 1 to 2 hours after eating. Before meal blood glucose shows if basal insulin or long-lasting insulin is sufficient. After meal blood glucose shows how different amounts of carbohydrate and insulin affect blood glucose. If the blood glucose is too high, that could mean the patient ate too many carbohydrates. If the blood glucose postprandially is too low, that could mean the patient did not eat enough carbohydrate. Always check portion sizes. Simple sugars digest and absorb in 15 to 30 minutes once eating them. Complex carbohydrates take 1 to 1.5 hours or more to digest and absorb. Fat and protein could take several hours to digest and to absorb. Some tools that can be used for carb counting include the ADA's Choose Your Foods book, Bose and Church's Food Values, the Calorie King, which is one of my personal favorites, and the ADA's Restaurant Guide. There are also several different smartphone applications that can be used. MyFitnessPal is one that I personally prefer. Let's move on now to coordinating food with type of diabetes medication. For insulin secretagogues, moderate amounts of carbohydrate at each meal and snack are recommended to reduce the risk of hypoglycemia. It is important to make sure the patient understands that they should eat a source of carbohydrate at meals, that they should eat 3 well-balanced meals per day and not skip meals, and that they should always carry a source of carbohydrate during physical activity. Biguanides, such as metformin, have various GI side effects. To minimize these GI side effects, it is important to take this medication with food or within 15 minutes after a meal. I always teach my patients to follow up with their healthcare provider if their side effects become unpleasant or last longer than 2 to 3 weeks. There is less risk of hypoglycemia with a biguanide than with insulin secretagogues, but it could still occur, and you should still recommend patients receiving this form of a drug to carry a carbohydrate with them. Alpha glucosidase inhibitors can also cause GI side effects, and it is important to teach your patient to take them at the start of a meal. There is less risk of hypoglycemia associated with this class of medication than with insulin secretagogues or insulin. However, in a patient who is on this medication, if they have hypoglycemia, they should only use pure forms of glucose to treat it, as this class of drug prevents the breakdown of complex sugars. So recommend that these patients carry glucose tablets or gel for treatment of their low blood sugar events. Incretin mimetics do have some GI side effects. They're usually pre-meal injection. They are lower risk for hypoglycemia than insulin or insulin secretagogues. Insulin therapy. If a patient is taking rapid-acting insulin, they need to take their insulin within 15 minutes of eating. I teach my patients to have their meal in front of them before taking it. Meals can be consumed at different times. With the rapid-acting insulins, which stay in the body for approximately 4 hours, it's less important that the patient has to eat their meals on the same schedule every day. However, I still recommend that they do eat 3 well-balanced meals a day. If physical activity is performed within 1 to 2 hours, it may mean that the patient needs to adjust their dose of the rapid-acting insulin to reduce risk of hypoglycemia. Patients who use rapid-acting insulin can either use it in an insulin-to-carb ratio, where the physician will tell them to inject 1 unit of rapid-acting insulin for every X grams of carbohydrate, or they could take it in a fixed daily rapid-acting insulin dose, which means then they would need to eat a consistent amount of carbohydrate at each meal with respect to time and amount, so that they eat enough carbohydrate to support the dose of rapid-acting insulin they are taking at that meal. For patients who are using a pre-mixed insulin, it's important that they take their insulin at consistent times. If the patient is on a mixed insulin like Humalog or Novolog 70/30, it's important that their food is in front of them when they take it. However, if they're prescribed Novolin or Humulin 70/30, it's important that they inject that insulin about 30 minutes prior to the meal. It's also important that they eat their meals at similar times every day and do not miss meals. They should always carry a source of quick acting carbohydrate, and a bedtime snack is probably going to be needed due to the peaking action of the insulin. If the patient is on a fixed insulin plan, such as just Lantus daily and no rapid-acting insulin, it's important to make sure the patient understands they should eat similar amounts of carbohydrates each day to match their insulin. That concludes the medical nutrition therapy portion of this course. Thank you for your time. I hope you enjoyed the session. Again, if you have questions, please feel free to email me or to post in a discussion board. Thank you.